To achieve the three objectives of hospitals safe from disasters, these are the factors that may put hospitals at risk, so that in order to support making hospitals safe, you have to look into the building, the patients, and because of the implication of disasters where you may have more than the usual number of patients to be catered to, thereby stretching the capacity of the hospital. Hospital beds may be less than what is the hospital may be attending to. Medical and support staff may themselves be victims also, and damage and loss of equipment and facilities, which can sometimes also surpass the cost of the structure itself. Now, to achieve this, we should take every opportunity to raise awareness by including this topic, and this is the reason why I think I was asked to speak about this today, on the agenda of high-level summits and technical meetings, and to document and share good practices, which I understand you have been doing since yesterday. We should also take into consideration all the key components of health service networks, such as primary health care centers, the blood banks, laboratories, warehouses, and emergency medical services. And we should involve the widest possible variety of professionals, not just of the health discipline, but we're talking of hospitals. So we're talking of engineers, architects, managers, maintenance staff, and more, in identifying and reducing the risk and building the resilience of communities and facilities. The objectives and measures are proposed on the basis of the strong evidence and in view of the high cost in millions of lives and billions of dollars lost in disasters. From past lessons, we learned that the most expensive hospital is the one that fails. The destruction of health facilities imposes heavy economic burdens to country and people. Next slide, please. Next slide, please. We learned that making hospitals and health facilities from disasters, maybe go back a slide now. Making them safe is possible, it is feasible, by including risk reduction in the design and construction of all new health facilities. Also, by reducing vulnerability in existing health facilities through reinforcement or rehabilitation. It has been estimated that the incorporation of mitigation measures into the design and construction of a new hospital will account for less than 4% of the total initial investment. And all hospitals should be built according to measures and standards that ensure the structural resilience, and all existing health facilities should be assessed to determine structural vulnerability and should be strengthened. Now, the health workforce, next slide please, are central to identifying potential health risks from natural hazards and for promoting personal and community risk reduction measures. And therefore, it is essential to strengthen disaster preparedness in the health sector. I understand, I'm pleased to know that the Philippines had launched they hosted the regional launch of the Safe Hospitals campaign 2 months ago, I think in August 2008. And many other member states in the region started developing their national plans and programs on hospitals safe for disaster. And I would like to urge those who are here and who are in a position to do so to initiate similar action in their own countries. Next slide. The ultimate goal of the campaign is to make sure that the assistance and the protection we provide meets the needs of all the population equally, and that those most affected by a disaster receive the support they need. However, this is not easy to achieve. There have been more and more evidence indicating that people living in low-income countries are 4 times more likely to die from extreme natural disasters than those in high-income countries. And women and men suffer different negative health consequences following a disaster. Next slide. For example, the tsunami of 2004 killed more women than men. In the 4 worst affected villages of Indonesia, females account for 77 to 80% of deaths. India and Sri Lanka also recorded disproportionately high number of female deaths. And these were mainly due to the fact that when the waves came, women stayed behind to look for their children and attempt to save the elderly, waiting on the shore for fishermen to bring in their catch, and were less experienced in swimming or climbing trees. Earthquakes more often cause more female deaths as women stay home with their children while men would spend more time in open areas. And studies also reported that an increase in delivery rates during 48 hours following an earthquake. There's significant increase in premature delivery, stillbirths, and other pregnancy-related complications. In Bangladesh, for example, the floods of 1998 resulted in increased urinary tract infections among adolescent girls, as they had no access to sanitation and clean water, which are important for female personal hygiene. Next slide. Female survivors. I'm going now more into the gender considerations, as this is also the theme for this Congress. The female survivors from disasters face more risks and challenges in the recovery period. Their domestic burden increases when their houses are destroyed and our assets lost. They have less chance to access information and external aid, as that men are efficient or automatically preferred as household heads in land distribution or other assets following disasters. And women have to stay in crowded shelters without privacy and sanitation, as I have mentioned earlier. Studies also reported substantial increases in levels of domestic and sexual violence against women and girls following disasters. Reproductive health and sexual health is beginning to be recognized as a key component of disaster relief efforts, given the examples that I have just mentioned. And we should all bear in mind that the need for gender-sensitive preparedness and responses to disasters, and to follow the principles of good practice if we are to ensure the appropriateness and the effectiveness of disaster reduction. Slide. It is clear that women are disproportionately affected, and in disaster response, women are not appropriately represented. Disaster response teams are often male-dominated and sometimes may lack of gender awareness and expertise. It should be noticed that women's particular needs and concerns and their potential for contribution are often disregarded in disaster preparedness. And I would like to emphasize that women are not only people who need care, they are also part of the main force in disaster response and care provision. And I think they look after, as I said, they look after the sick, they look after the elderly before they look after themselves. And therefore, the principles of good practice, if we are to ensure that our disaster response and preparedness are sensitive to the needs of those who are disproportionately affected, should follow these following principles. We should be involving women in all stages of decision-making, identify and provide for sex-specific needs, consider and assess the impact of all response activities on women, and ensure that distribution of assistance allows women access to relief, aid, and supplies. We should make hospitals and health facilities not only safer, but also more responsive to the needs of women, men, girls, and boys, the elderly, and the poor. Female health workers should be equally represented and protected. and their participation in making hospitals safe and in disaster response and mitigation is essential.